segmental butterfly or splintered. This one is a butterfly. You can see it kind of takes the shape of a wing, wings of a butterfly. This one is segmental, meaning that usually comminuted has to do with a crushing type. So it may not break into small fragmented pieces, but it could break into segments. And then obviously we see that splintered, where we start to see maybe a piece or fragment off to the sides. And this is very sharp. One of the things that I really want you to pay attention to when you are experiencing trauma type patients that are coming in with breaks, fractures, we don't want to move. We don't want to move because this is a sharp edge. So when it's sharp like that, what does it have the ability to do? It has the ability to tear. It has the ability to tear through muscle. It has the ability to tear through vessels. And it has the ability to tear through skin. Got it? You could cause more trauma by trying to move this patient as opposed to working around the patient. Make sense? It's not about being easy for you. It's about doing what's right for the patient. Make sense? So just keep that in mind before you start rotating your patient into a true AP and lateral. Okay? So this is another image that you have in your PowerPoint. You can go through it. You can go through it and just kind of review the different shapes, the different looks of the fracture, and they make sense, right? Segmental, comminuted, oblique, spiral, and transverse. So that's just the alignment of the fracture itself. We talked about impacted fractures. Remind me of what impacted fractures are, son.
That is the fragment that is driving one out.
It is. It is. You have a shortened end because it is driven into the other end. And we know that the epiphysis is wider than the shaft, right? We know that the epiphysis is wider than the shaft. What is an epiphysis, Tracy? Unmute, Tracy.
I'm look at the material right now.
The epiphysis? Mr. Donahue went over what the epiphysis is when we went over anatomy. So let me know when you find it. I'll come back to you, Tracy. So I'm going to go ahead and get to somebody else, but be ready for the next one. Okay, Amy said it. It is the large end of the bone. So the shaft is pretty narrow. The epiphysis is where all the magic happens. So we want to make sure that we are ready for something like this. So you were given anatomy. You were given anatomy. On your slides that I provided for you, you have this. So my expectations is nothing less than your knowledge of being able, I can point anywhere. I can point at any location, and you should be able to identify it because this is repetitive information. This is not new information. This is repetitive. I did not place any lower extremity for anatomy identification because you're not quite there yet. Make sense? Good. Any questions on this? All right, Wani, what does this that I'm pointing at, what is that?
I don't see where you're pointing, Miss Laura. Oh,
you can't
right there?
Yeah.
Will be the...
I'm looking at the space.
PIP?
Okay. There's about four.
Is the head of the...
No, I want the PIP, but there's about four of them. Wani?
Is the 1 to 5th?
The fifth PIP, so of the right hand, because we see the right, correct?
Yes.
Good, Sharon. What is G pointing at?
Second MCP.
The second MCP. Perfect. And Marcella, give me A.
Is it the first CMC?
Okay, good. And Luke, what is this, carpal?
Is it the capitum?
There you go. Very good. Capitate, right? Awesome. Perfect. Now let's move on. So you have, just in case you may have forgotten, you have an opportunity to go back. I gave you the humerus. I did not put a clavicle or scapula on here. However, I know I'm pretty confident that you guys would be able to identify that as well, as we are wrapping up the shoulder girdle, correct? You guys are testing out in lab, and now you're moving on into lower extremities. Yes? Have you had your test for shoulder girdle? What, Jessley? I can't hear you.
Later today, like for lecture.
Today. Well, this is a wonderful review. You could go back and look at this and say, wow, Miss Lara's on point. She gave me the humerus and I have it. So I am ready for Mr. Donahue. So y'all have a test today. Mm-hmm. This is why we're kind of quiet. So let me get you guys warmed up. Get you guys warmed up and ready to go. So now we're going to move into fractures, and this is chapter 4, fractures. And if you notice right here, I start to have, now I know that this one is highlighted in red, because, and then you're going to think, oh, that's the only one, but actually not. All of these are going to be equally important, because what happens is all of these are significantly different. Except for the Kayes and the Smith, which we know are having to involve the distal radius, the Benet fracture, which we see quite often, and the Boxer fracture, which we see much more often, is informative so that you understand. Now, Esbedi, can you read to me what is the Benet fracture? What is the Benet fracture defined?
That one I'm not sure, but I think it's like when you dislocate the like the thumb area, like when you have like a dislocation. I don't know how to explain it. I just look at the images. I'm sorry.
It's a feature that's at the base of the first metacarpal. Is that correct, Ms. Lara? Can you hear me? Can you guys hear me? Yeah, okay, just checking.
Miss Laura.
That's crazy. Oh my gosh. That is wow. Oh god. Okay, I'm sorry. Go ahead. We're back. And I'm at work. I'm not at home. So I just want y'all to know that I'm at work today. I'm on a landline. So okay, go ahead. Who had a question? I heard somebody say Miss Laura.
I saw an email and you say your connection is out.
Oh, thank you. Yeah, I'm glad y'all stayed on. I'm glad y'all hung with me because I was trying to let you know I'm trying to connect back, but it wasn't letting me. It just kept spinning. All right, so let me try this again. Okay, so what was the Benet?
First medical.
It has to deal with the first metacarpal. It has to deal with the first metacarpal. So when you go back and you look at the Benet, you're looking at the first metacarpal. It's right at the base. It's not the first metacarpal in its totality. It's at the base of the first metacarpal. So we can see that here is the first. We can see that with the sesamoid bone identified and the way that the first digit is positioned. So here we see that Benet fracture. The boxer fracture is actually opposite. It's actually opposite. When someone comes in and they're coming in for an x-ray, they'll usually have some swelling here around the fifth metacarpal. You'll start to see some type of deformity, some type of swelling, discoloration, and you can already pretty much guess that this is called they've broken or fractured the metacarpal, the fifth one, not the first one, but the fifth one. So the Benet's is the first one, base of the first. The boxer is the fifth metacarpal. Sometimes it's usually mid-shaft or towards the head of the metacarpal. How does one get a boxer's fracture? It's in the name. Hitting. Most of the time I'll see this. Not as common on women, but definitely more common, my experience with men. Punching a wall, punching something. So that's usually how this happens. Okay, so you have your boxer fracture and you have your Benet. We've already talked about the Caillet's fracture and the Smith. So here are some pictures just to kind of give you an idea of what the difference between one versus the other. You have Caillet's, you're going to have a posterior type of displacement of the joint, and for the Smith, you're going to have an anterior type displacement of that articulation. So already had a quiz on that, already had a test on that, so I'm not too concerned with it, but I do want you to know that the Smith is the reverse Caillet. Okay? Any questions there before we move into pathology away from fractures? I feel like I'm in a race, like I'm going to lose you guys again, so I want to get some of this out. Okay, so we have bone metastasis, tumors, bursitis, Pageants Disease, Rheumatoid Arthritis, Osteogenic sarcoma, or short, Osteosarcoma, chondrosarcoma, and then we have our Osteoarthritis, Osteomyelitis, which aren't all meaning the same. What does osteo entail? What does osteo mean? Bone. And we know what itis is because itis means what? Inflammation. So that you know that you're going to see some type of maybe infection or inflammation to this. And then we have osteopetrosis and osteoporosis. Two separate things. Even though they may be considered similar because of the way that they look, they're absolutely not. Okay, one is atrophy and one is hardening, and we're going to get to that. All right, any questions before we get started? So when we look at tumors, what is metastasis, Amy?
Isn't it when it keeps growing?
Spreading. Yeah. The cancer starts to spread, whether in most cases it's usually malignant. Not necessarily benign. What's the difference between malignant and benign, Juan? Malignant and benign tumors. What's the difference?
It's one of it. The benign is going to be the first metacarpal, and is that?
Now, benign means what type of tumor, and malignant means what? So, malignant and benign are different because benign is non-cancerous and malignant is cancerous.
Oh,
Okay, so but either way, good. We have a tumor, and so what is happening? It looks like it's a fracture. Thank you, Duan. It looks like it's a fracture. Can everyone see? It's kind of hazy because I've enlarged it. But can you see that there is a brightness change on this bone? Does everyone see that? When you start to look at the defined lines of the upper humeri versus the shaft of the lower humeri, we start to see that there is a change, a discoloration, indicating something is there, right? The x-rays interacted differently here than it did here and here. Make sense? Yes? Good. So depending on what this looks like, it looks like it is a tumor of the bone because it's starting to break down. It is starting to break down the stability of the bone. Not a fracture because it doesn't take the shape of an oblique. It doesn't take the shape of a transverse. It doesn't take the shape of a spiral. It doesn't take the shape of a comminuted. It starts to look, because of this change here, that there is some type of erosion, okay? And eating away. And remember, tumors survive by depriving the tissues around the tumor from nutrients. Make sense? Yes? Thumbs up? Perfect. So when we look at bone metastasis, we know that bone metastasis is a type of cancer or a type of tumors that are spreading from section to section. Tumors are basically either benign or malignant, and they start to feed or deprive off of the area's nutrients, okay? And so you'll start to see areas like this, discoloration. Are there any questions? Yes, it would be referred to as a minus density. You see that? You definitely start to see the brightness go down into darker, and so that looks odd. And so when we're identifying pathology, we're looking for inconsistencies in those brightness. Very good, Marisela. All right, bursitis. So when someone has bursitis, tell me what bursitis means, John.
Yeah, the bursa, like in the bone joints, is inflamed.
Inflamed, and it is filling up with fluid. It is filling up with fluid and inflamed. In this inflammation, it's just producing more fluid. And so when you see someone coming in, and this is more of a common area in the elbow, you can see that there is an obvious deformity. There is an obvious deformity. And the first thing that you're going to think, oh, well, you know, it's a mass. Not necessarily, because of a joint. And what type of joints do we have? Is this a diarthrodial joint that we have here, Jaleisha?
Diarthrodial. Yes.
Yes. Okay, and it is filled with synovium, right? Synovial fluid. So that synovial fluid will start to accumulate, and so basically this becomes a sac full of fluid. So how do we relieve this? Well, we first have to start finding out why we're having this. But most patients will have a syringe inserted by the radiologist to extract, or the physician, to extract some of that fluid, okay? So we can see what that looks like. So this is called bursitis. Any questions there? All right, Jolie, read to me for what is Pageants disease.
I think that it infects the bone and the basin cannot work.
Are you reading it from the chapter 4?
It's the chronic skeletal disease.
It's a skeletal disease. Keep going. All the way through.
Characterized by bone destruction followed by reparative process of overproduction of very dense soft bone that tend to fracture easily.
Beautiful. Thank you so much. So it is the destruction. So when I say osteoclast and osteoblast, what does that mean? Osteoclast and osteoblast. Anyone?
Bone cells?
Bone cells. So there are two types of bone cells. One that's going to destroy, break down, and one that is going to rebuild. So which one destroys and which one rebuilds?
Blast destroys and blast rebuild.
There we go. So what is happening here, this is a type of skeletal disease that starts to break down its own bone. But in the process of breaking it down with the osteoblast is coming back in full overproduction. But the problem is it's very soft. It's very soft bone that is being formed. And you can see if you try to continue to walk, and if the bone is soft, you start to mold the bones. So this is why you're able to see this anomaly here from this patient, so and compared to the normal side. So this person has an obvious Pageants disease because we can see that deformity. That is not usually occurrent from a big break. That is the remolding, the reformation of the bone, soft bone. Any questions? No? All right. Now we're going to go ahead and move into rheumatoid arthritis. Now this one is a common one. This one is a common one. You'll find this most likely in women or men. Javier, will you have to find this mostly in women or men? It says it right in the definition.
I believe it's in men, if I can remember.
More women. I think Pageants disease is more men, but you're right. I was more women. So more women are likely to have rheumatoid arthritis. So Javier, don't stop. Read the definition for me. Rheumatoid arthritis.
On page 140.
Thank you. I'll come back to you, Javier. Let me go ahead and get Tracy. Tracy, read the definition for rheumatoid arthritis.
Okay. It is a chronic systematic disease with inflammatory changes throughout the connective tissue. The earliest is soft tissue swelling is prevalent around the ulnar styloid of the wrist.
Very good. And so what we're looking, thank you, Tracy. And so what we're looking at here is a depiction of you can start to see the swelling. So what you notice, and especially, and it is a systemic disease where it starts to affect the entire system, but it's very obvious in the hands. So what happens, the swelling starts, and then the eroding of the actual joint, it starts to lose its stability. And you'll see this by the enlargements of joints. Has anyone seen patients coming in with different types or large, like knuckles, very round knuckles? No, not yet. One of the trait or a progressive or chronic onset of rheumatoid arthritis, we call it swanning. There is a swanning of the fingers. So you can have your hand straight out like this, your wrist can be straight, but the fingers are going to swan towards the pinkies. So you can see here the patient is trying to be in a PA, and the digits are going to start swanning to the medial surface, to the medial side. Okay, And so you'll see that, and that is a classic sign of progressed rheumatoid arthritis. Any questions? You may have family members that have this type of condition and never knew that it was, but a classic sign is the swanning of the digits. All right. Any questions there? Mm-hmm.
Systemic disease, that's just the same thing as autoimmune disease, is that right?
Autoimmune, absolutely. Autoimmune disorder. And what is that? What is an autoimmune disorder?
Just when the body's attacking itself.
Body is attacking itself. It doesn't recognize the normal anatomy and considers it foreign, so it starts to destroy it. And so, yes, and so many of the treatments now is just to take medication to keep the inflammation down and further eroding of the tissue around it. Yeah, definitely. It's a progressive. As it becomes more and more progressive, it becomes more deformative. It creates more of a deformity of the hand and loss of function. So it really, really is a very sad to witness. So, and it's, and then the pain, because a lot of times when people have arthritis, how many of you have arthritis? I know I do.
No.
You feel it when the weather changes. Your hands may start to ache a little bit. No? Young class. Gotcha. All right. Well, maybe later. And so, as you start to see maybe feeling pain in your knees, that's usually where you start, and then eventually it'll start to feel pain in your hand, and it's just like a throbbing discomfort, and that's usually a sign of arthritic changes in your hands and the swelling. And why it's weather related, I mean, it's obviously temperature related, but it's painful.
Okay.
Did I answer your question, Jonathan? Awesome. So osteogenic sarcoma or osteosarcoma and chondrosarcoma, what's the difference between those? Look at the prefixes. One says osteo and one says chondro. What is chondro?
Ligament or cartilage?
Cartilage. Very good. Very good. So when we start to look at these, so Jonan, can you
Would
go
you
ahead
stop
and read
it?
two? Sorry?
Here. Sorry.
Yes, Mr. Alicia?
Sorry,
Okay.
my cat.
All right. Jonan, can you go ahead and read those two for me so that we can determine what the differences are?
So osteogenic sarcoma is second most common type of primary bone cancer. It's a malignant cancer forming in the bone.
Okay.
And then chondrosarcoma is a slow-growing malignant tumor of cartilage.
Cartilage.
Dense calcifications.
I'm sorry, go ahead.
I was just saying with dense calcifications within the cartilaginous mass.
Yes. And so where would you find cartilage at? Inside of the bone and the bone region. Not necessarily in the joints. I know that you'll find cartilage there, especially when you have two articulating joints that have diarthroidal movement. But what are we talking about? Where else would we find cartilage in the bone?
In the bone?
Not on the computer.
I mean, I don't know, I'm just thinking, I know
Not
there's
on the
cartilage in the
computer.
ear, there's cartilage in the nose. Within the bone, I just thought it was at the ends.
It is at the end, absolutely. So you have this hyaline cartilage that eventually starts to fuse and become very fibrous. And so this is where we would start to see that chondrosarcoma, where we had the epiphyseal plate, where we had once our epiphyseal plate. Remember, because that is where our cartilage to allow us to grow to our tallest possibilities. So with that being said, so that's the two differences between them. And I found this image here of an osteosarcoma, which is a very common type of tumor, malignant tumor of the bone. You can see that here is the epiphyseal plate, or what was once the epiphyseal plate of this individual. But here you start to see right at the epiphyseal area, because we know that the greater trochanter, the lesser trochanter, and right here at the neck, we have some cartilage. And so that's where we have this type of cancer. Ewing sarcoma, it's also in your book. It just came with the picture. I'm not going to go into that. I really want you to start paying attention and putting your words together. putting your words together and you're looking at your prefixes and looking at your suffixes. Okay? Good. Perfect. Any questions here? All right, moving on. Osteoarthritis. And we talked about rheumatoid arthritis, but osteoarthritis is also known as what? Let me go to Aurora. What is osteoarthritis also known as? Please put this down on your notes. Please make sure that you are reading your definitions. We may have a lot of matching on your test.
So the definition says it's also known as degenerative joint disease, DJD.
DJD, degenerative joint disease. So this is my wonderful class of 22. This is degenerative, basically meaning as we age and we produce a long life, our bodies are going to start eroding. Our calcium supplements will start to decline. So osteoarthritis is basically starting to mark those types of erosions. So let's take a look at this image over here to the left. We can take a look and see at these joint spaces. It's pretty sharp. These joint spaces, they don't have a lot of space, but look at the outline of the metacarpals. Look at the bases of the proximal phalangeals. Look at those. They're pretty outlined. They're pretty sharp. You can see the cortical, the hard bone. You can see the soft bone, and so on and so forth. But if you start to progress distally, we start to see a change in shape. The outlines don't look sharp as normal anymore. It starts to become hazy. It starts to become blurry in a sense. It doesn't look sharp outlines. It kind of starts to spread out a little bit. That is signs. You see this right here, very different from this one. So this one has more of that erosion, that degenerative action of this joint. So here we start to see the losing of these sharp outlines, starting to see the loss of these sharp outlines, and start to see them kind of mesh together. Does everyone see that? So you can take a look. Right here, pretty sharp, doesn't it? Right? Start to see a nice normal hand. You guys let's go back and take a look at it, what a normal hand looks like. See how everything is pretty sharp and outlined? There's nothing that is meshing or growing together. All of the phalanges have sharp outlines, and you can tell where is the space versus the next bone. But when we start to see osteoarthritis, we will start to see changes in those joints. We will start to see them almost run together. We can see swelling. So you start to lose those sharp outlines, and you start to get, like, for here sharp, but here it's not. You see that there is some type of growth. So get a good look, go back. Everyone should be looking to see and maybe pulling up Google, Yahoo, whatever your search engine preference is. Start putting in these. Start to get an idea. Match your definitions with what your pathology is. So you get a better idea. Got it? I know it's a little smaller, but you know what a normal hand looks like, and you can see these obvious changes. So degenerative joint disease or osteoarthritis happens to most of the population that lives a long, long life. Osteomyelitis. Esaias, read it for me.
Is that like infection to the bone?
Mm-hmm. Why? Where do we get an infection to the bone? How do we get that? It says it right there.
I don't have the book right now. Sorry.
Okay. All right. Who has it? Can help Esaias out.
By bacteria?
By bacteria, sometimes introduced into the body, whether through trauma, right? Or an illness. So osteomyelitis is a serious type of infection. of the bone and the, what is Maya? What is Maya?
Is it muscle?
Muscle. So not only do we have infection of the bone, we also have infection of the surrounding muscle. So remember, bones provide structural stability. Muscles allow physiology to happen, movement, right? Rotation, pronation, supination, all of those types of movement. So when you damage the muscle, not only the structural stability, can everyone see here? So what we're looking at is a foot. We are looking at MTPs, metatarpals and phalanges. So here we see the fifth metatarpal has the head missing. It's been eroded. This is an infection. It almost gives you a clinical sign that it could be a tumor, depending on what is entailing around the muscle. And it's very difficult to see in this image, but you can start to see some changes in the muscle area. Very difficult to see, but I encourage you guys to go and explore these pathologies and looking at radiographs as you start to get more knowledgeable of what it looks like. But remember, we're focusing. So how often do we see osteomyelitis? Well, we see it pretty frequently. Does anybody know what I'm looking at? Does anybody experience what this is? Are you going to be okay? We're going to be okay? I know, wakey. What is this? How many of you have had experience with this so far?
Is that a diabetic ulcer?
It is a diabetic ulcer. It is a diabetic ulcer of the foot. And so what happens is, yes, this is an infection, and this is stemming from actual diabetes. So the patient may have hurt themselves, something, whatever caused trauma. The actual infection started to grow, and you can start to see on this radiograph that you're starting to see bone changes. This infection is eating away at the bone, okay? And it can start looking like this. So if you bring a patient back and they have a diabetic foot ulcer, many times, people will go into amputation to stop it, okay? Many times people will go into amputation to stop it. So osteomyelitis is the real deal, right? You definitely don't want to handle any patients without any gloves, right? I would never walk into a room and see any of my people handling a patient without gloves, correct? Yes? Yay! All right. So as you can see, and when you get into the lower extremities, you'll start to see that this does not look like a normal bone or a lateral foot. You're going to see that there is some type of changes. Does everyone see that roundness and that brightness? Well, when you start to see brightness, what happens on a radiograph? What is the radiograph indicating that this brightness could be? What is going to, it's absorbing x-rays, right? Yes, so we're absorbing x-rays, so it kind of takes on the same appearance as the bone itself. So it's either absorbing, whether this is going to be more fluid in the area that is going to absorb those x-rays equally like it would the foot, or you start to see some calcification. Okay? Any questions?
So is that because of, you said because of the fluid and calcification, that it absorbs more of the x-ray?
Right. Remember, okay, so the heart is not made out of bone, is it? The heart is made out of muscle and tissue and so on and so forth, but it absorbs x-rays differently than it does the lungs. So it doesn't necessarily need to be bone to absorb x-rays. It just has to be tissue on top of tissue on top of tissue to absorb x-rays and show something different. So this could have, because we start to see this round kind of brightness, there are two things. You have excess of fluid, excess of tissue, or you start to have calcifications, which is osteoclast breaking down and osteoblast building up. Okay? answer your question? And this is a lot. So, I mean, this is something that you're just getting familiar with, but I wanted to show you this is the most common reason that we'll see osteomyelitis from. Okay. All right. Osteoporosis. Osteoporosis. Now, osteoporosis, we have healthy bone, and this is what if we were to slice a bone in half, this is the femur. If we were to slice this bone half and sideways, we would see all of these channels of healthy bone, right? So we have a surplus, but osteoporosis means an atrophy. It's a decline. We start to see these channels become enlarged. When we start to see channels become enlarged, we're losing bone in between the channels. So what happens when we start to lose our structural stability within a bone? Luke, what happens when we start to lose the structural stability within a bone?
It becomes weaker.
It becomes weaker and inclined to do what?
Breaking.
So our bones become weaker, but we don't become lighter. So with the weight that we put onto our bones, or the pressure or the stress that we put onto our bones, our own weight can break our bones. Does that make sense? We don't have to go out and have a traumatic experience. We can step off of a curb and break our bone with the weight that we step down on. So people with osteoporosis or severe osteoporosis have to take calcium supplements. Just try to start putting back that calcium in their body, and they have to be very careful about what they do and how they do. Okay? So where do we test? Where do we measure osteoporosis within Harris Health? What department do we do that in?
Bone density?
Bone density. So bone density specific purpose is to see this. See how this is dense with bone? Here is the loss of that bone dense. So what bone density is doing is going back and measuring how dense is the bone and what's the probability of fracture. Okay? So why is this important? Because fractures can lead to infections or lead to surgical procedures. So we want to make sure that we can prevent any fractures, right? And where do we mostly see osteoporosis? What population do we mostly worry about with osteoporosis?
Geriatrics?
The geriatrics. And so they're always one of the biggest fears that they have. Naomi, do you know what that is? One of the biggest fears? I think we talked about it back in patient care for summer.
Sorry, I didn't hear the question.
What was one of the biggest fears that people with a geriatric population have? Falling, absolutely falling. Because one of the most common sites, as you're going to learn in the lower extremity, when you get to the pelvic girdle, one of the most common fractures for that population is the hip fracture. So this is why the hip is most commonly done in bone density. Okay, they want to see what the probability of that fracture rate is going to be for that individual, right? And then they'll go into different types of treatment. Any questions there? Osteoporosis. Well, don't get confused with osteoporosis with osteopetrosis. So osteoporosis looks like this. See how this is becoming dark? See how this is becoming dark? We didn't do anything magical with our x-rays. We didn't make this darker in our x-rays and this lighter for a reason. We don't have that capability. We do not have the capability to regulate our primary beam so that one part of a bone gets darker and the other part doesn't. So what this is a revelation of pathology. So we start to see darker shades. Darker shades means radio-opaque or radiolucent. Daniel.
Radio-opaque.
Are you sure? Darker areas?
Brighter
areas? Not
darker,
brighter areas. Darker
radiolucent.
areas. Radiolucent. That means that x-rays are transmitting. We're going to bring in a little bit of PRE. X-rays are transmitting more effectively here in these areas than here in the bodies of the metacarpals. Make sense? kept saying metatarsals. It's metatarsals. I knew I was saying that wrong. I need more of this. Okay, so we start to see that loss of calcium, and we see it pretty significantly, right? Pretty evenly distributed all the way around. So when you look at this type of wrist, you're thinking, we shouldn't be catching baseballs at that point. All right. Now, osteopetrosis. Let me see. Who have I not called on yet? Sharon, what is osteopetrosis? Sounds like something Harry Potter would say. Osteopetrosis.
It's a hereditary disease marked by abnormal dense bone.
It looks, and it's also AKA called marble bone. It's also called marble bone. So the difference between osteoporosis and osteopetrosis is the fact that we can see normal bone, and here we would think, that looks just like osteoporosis because we have bigger channels. Problem is this disease is making these bones that are creating those channels hard, super hard, not withering away, but replacing it with super hard bone. It becomes very dense, very difficult to x-ray. Becomes more difficult to x-ray. It becomes very dense, okay? So when you look at normal bone, you have normal calcium, but when you go back and you look at osteopetrosis, you start to see a thick, denser population of osteoblasts in that area, in those channels. Make sense? So osteoporosis is not osteopetrosis. Sounds similar, but one is atrophy, one is withering away, and the other one is building. Questions? No? Okay. All right. So we have made it to chapter 5. Chapter 5, these are the types of areas that we're going to cover. Rotator cuff, Hill-Sachs defect. Where have you seen Hill-Sachs defect? And what projection for the shoulder girdle? I'm going to go ahead and prepare you for your test today. Hill-Sachs defect. Where have you seen, which projection would identify the Hill-Sachs defect?
Is that Grashi method?
Which one?
Grashi?
The Grashi method? Okay, I like it. Hill-Sachs defect? What is the Hill-Sachs defect?
It's a fracture.
Just a fracture?
It's a compression fracture.
A compression fracture.
The humerus.
Okay. I'm not 100% sure about the Gracie method, but I know that you can see it in the Lawrence method with the external rotation, the inferior superior, that you are able to see the Hill-Sachs defect. But I will double check with the Gracie method being part of the Hill-Sachs defect. So some of this information you probably already know. AC joint separation. What does AC stand for? Wani.
Acromioclavicular joint.
Beautiful. Look at this. I even put bursitis on here, but there is a bursitis of the shoulder. We'll briefly go over it, but you already know what bursitis is. We've already talked about it. So we really are looking at these 4, and when we come back on Monday, we will be finishing chapter 5 and chapter 6. So please, please, please be ready for me so that we can get you up and running into your modules. But starting Friday, you should be working on module 10. Working on completing the quizzes. Those will be your assignment grades. So make sure you score high. Set yourself up high for this next exam. Make sense? Yeah? Well, good luck on your test, but I'll see you in an hour and a half or so. All right? Any questions before I leave you for pathology? And hopefully we don't have any more hiccups.
Question.
Uh-huh.
Yeah, for the tutoring, what time will you start?
The what?
At Kirby.
The tutoring. I guess it wouldn't be able to start anything less earlier than your last class. So I just need someone, and if you're coming, I need to know when you're coming so I can wait for you. I won't be just waiting, hoping, pushing, praying. So just let me know if you're deciding to come. Anything else? Au revoir. See you in a little bit.